Hello, everyone. Good evening, or I'm recording this in the evening, whatever time you're watching it. So this lecture I'm about to record is going to be for Monday, March 16th. I have some last minute things that I have to do involving a faculty search and things like that. I didn't really realize about this until the last minute. So I'm recording this on Sunday, but this lecture will serve to replace Monday, March 16th. Okay, so we are going to kind of pick up right where we left off. This is the slide we left off on. I am going to go over just a couple more things on this slide because I think I rushed through this at the end. But this is the categories for the diagnosis of prediabetes and diabetes. And these are numbers that you do have to remember. Kind of talking about the conditions that are required to diagnose diabetes and prediabetes. And there's two major tests that are used in this diagnosis of diabetes. And the first one is that fasting plasma glucose. We talked about that a lot, that a normal fasting plasma glucose is less than 100 milligrams per deciliter. Impaired is between 100 and 125. And then a fasting plasma glucose of over 126 is considered diagnostic for diabetes mellitus. And this is by far the most common method of diagnosis is the fasting plasma glucose. The second type is this 2-hour post-load glucose, where you're basically introduced to a specific amount of glucose. Usually through some kind of drink, but there is, I've read of things where people do where you have to eat a certain amount of gummy bears or jelly beans or something like that. But most of the time, you are given a specific amount of glucose and you have to see how your blood sugar responds 2 hours after eating a specific amount of glucose. And this type of testing, this 2-hour post-load glucose, is more commonly done during pregnancy. Not that it can't be done in other circumstances, but this is the most common time that you are going to see this type of testing. And in a normal person or a typical person, after they are introduced to a specific amount of glucose, their 2-hour post-load glucose is going to be less than 140 milligrams per deciliter. So again, notice that that's not what we would consider typical for a fasting glucose. This is, we have eaten 2 hours before. It's perfectly normal for somebody's glucose to be 120, 130. Prediabetes or impaired glucose tolerance is a 2-hour post-load glucose of 140 to 199, and then a 2-hour post-load glucose of greater than 200 milligrams per deciliter is what we would call provisionally diagnostic. This result, as we talked about before, does need to be confirmed with a fasting plasma glucose test. But it has been shown that this 2-hour post-load glucose is much more effective at catching gestational diabetes than just a fasting plasma glucose. So that is why that test is typically used during pregnancy, is to check for that gestational diabetes. Okay, so this is just a little mini case, and I'm going to give you guys the answers, but I recommend that when you're listening to this that you read the question, pause it, see if you can figure it out yourself, and then listen to the answers. But Mary is a 55-year-old woman with a BMI of 28, visited her primary care physician with complaints of increased thirst and frequent urination. Her physician ordered a chemistry panel and a urinalysis, and the following results came back. So her physician ordered a chemistry panel and urinalysis, likely because of this increased thirst and frequent urination. That's two of the P's, right? The increased urination, polyuria, and increased thirst, polydipsia, are two of the really common symptoms of diabetes, particularly type 2, but type 1 as well. And her random, so she just went to the doctor and her random glucose was 220 milligrams per deciliter. But her urinalysis, which we're going to talk more about in a second, we haven't really covered this, but her urinalysis also shows glucose in her urine. So this glucose in her urine, this is abnormal. Your urine is never supposed to have glucose in it. Sugar in your urine is an abnormal state, always. It's not a typical thing. Now, her random glucose, sorry, let's see. Yeah, there it is. Sorry, I couldn't see it. So her random glucose was 220 milligrams per deciliter, which is higher than this random plasma glucose of 200 milligrams per deciliter, that kind of criteria for diagnosing diabetes mellitus. So what is Mary's probable diagnosis? Her probable diagnosis is diabetes mellitus because that random glucose is over 200 milligrams per deciliter. However, it cannot be said that that is her definitive diagnosis, and that is because she hasn't had a fasting plasma glucose. A fasting plasma glucose is always going to be the diagnostic for diabetes mellitus. So what follow-up tests are recommended by the ADA is going to be a fasting plasma glucose. All right, and then we have a second mini case. Mike, a 60-year-old man, had the following laboratory results on a blood work ordered during his annual physical. His fasting glucose was 124. Confirmatory tests were ordered just to double check that fasting glucose to make sure that he wasn't just out for one day, or maybe he is misremembering when he last ate, things like that. So his fasting glucose was above 100, but less than 126. Remember that 126 is kind of the benchmark for diagnosing diabetes. So are these results abnormal? Yes, they are abnormal. His results, his fasting glucoses are both high, as is his 2-hour post-load glucose. So what is the correct terminology for these glucose levels? If you look at both of these on this chart, if you look at his fasting plasma glucose levels and his 2-hour post-load levels, they both fall into that pre-diabetic range, or the impaired glucose metabolism stage. So he's in a stage where he is pre-diabetic. He would not be diagnosed as diabetic quite yet. His glucose levels are not quite high enough for that. However, he is on the way to becoming diabetic. So the physician's next step typically would be not to go straight to medicine and things like that, but it would be trying to control this diabetes with diet and exercise. It's possible, I talked a little bit about this last time, that these drugs like GLP-1s, Mounjaro, Ozempic, things like that, were originally developed to treat diabetes mellitus and insulin resistance. And so a lot of the procedures on this kind of stuff is very new, and I don't know a lot about it, but I do believe that it is possible that some doctors would treat at this stage with a GLP-1 to try to get that insulin resistance back down to normal. And the doctor will also order repeat testing regularly to make sure that his blood glucose levels are being monitored, so that if he ever does become diabetic, that we would know. Okay. And would Mike be classified as a diabetic? The answer is no. As of right now, no, because his fasting plasma glucoses and his 2-hour post-load glucoses don't put him in that range. And what are the chances that he will develop diabetes? The chances are very high. When somebody has impaired fasting glucose, that's usually just a stepping stone to developing diabetes. So if changes are not made in his diet and exercise, possibly the addition of a GLP-1 depending on the rules. Like I said, a lot of those procedures are very new, and I'm not super familiar with them. But the chances that he will develop diabetes, especially if he doesn't change his living habits, the chances are very high. Okay, so we just spent a lot of time covering diabetes. As you can probably tell, diabetes is one of the most significant disorders when it relates to carbohydrates. But we are going to cover a couple of other ones. There are a few more. They're much quicker. But so our other disorders or diseases that relate to carbohydrate and carbohydrate metabolism, our first one is going to be hypoglycemia. So diabetes mellitus, all 4 types, are related to hyperglycemia, where your glucose levels or sugar levels in your blood are too high, chronically too high. Hypoglycemia, as you guys know, hypo is low. So this is a disease characterized by low glucose levels. And when I mean low, hypoglycemia is usually defined as below 55 milligrams per deciliter. So not quite, we typically consider normal between 70 and 100, but hypoglycemia doesn't typically start till below 55. And hypoglycemia is actually diagnosed using something called Whipple's triad, which is a series of 3 criteria that have to be met in order for a person to be diagnosed with hypoglycemia. And the reason that this is true, or one of the reasons that this is true, is one of the symptoms is a plasma glucose below 55 milligrams per deciliter. That should make sense. Hypoglycemia is a blood glucose less than 55. However, not everybody's bodies are just a little bit different. And not everybody who has a plasma glucose of 55 milligrams per deciliter is going to experience actual disease symptoms. So for some people, a plasma glucose of less than 55 is normal, especially people who have type 1 diabetes. So hypoglycemia isn't diagnosed just with a blood test. There are other things that have to be true in order for a person to be diagnosed with hypoglycemia. Okay, and one of them is that they have to be symptomatic. Because again, there are some people that can have a blood glucose level of 50 and be perfectly fine. They would not be considered hypoglycemic, even though their blood levels are low. So symptoms of hypoglycemia are things like sweating, shakiness, anxiety, hunger, weakness, dizziness, confusion. Basically, the symptoms, if you've ever had where you've just gone way too many hours without eating, and you're almost sick, you're so hungry, where you get shaky, you get weak, sometimes you get dizzy, or if you've gotten extremely hungry, confused. But it's all to a bigger extreme. So those are the symptoms. And then the third, point of Whipple's triad is the reversal of symptoms after a carbohydrate load. So things like sweating, shakiness, anxiety, hunger, weakness, those symptoms are so generic. There are so many symptoms or so many syndromes and diseases that can happen, that can have symptoms of sweating and shakiness, anxiety being one of them. If somebody is really anxious, they'll sweat, they have shakiness, weakness, dizziness. So to have somebody be truly diagnosed with hypoglycemia, the third thing that has to be true is that their symptoms are reversed. So we have a complete reversal of all of those symptoms as soon as they consume some type of carbohydrate. And hypoglycemia can be incredibly serious. It can lead to coma and death if it's not treated quickly. And there's a couple of different types of hypoglycemia. By far, the most common type of hypoglycemia is going to be drug-induced hypoglycemia. And drug-induced usually comes from the injection of insulin, usually from people who have type 1 diabetes. So people who live with type 1 diabetes have to inject themselves with insulin multiple times per day. I think most people who live with diabetes currently wear like wearable and replaceable insulin pumps and glucose monitors. I don't know if anybody in our class, or I know I've had people in my class that have it before. And a lot of times they'll have like glucose monitors and things like that on the backs of their arms or the backs of their legs, things like that. But type 1 diabetes is a balancing act of guessing how your body is going to respond to carbs. And a lot of times it can be really predictable. You know, if you eat 30 grams of carbs, you need this much insulin. But it's not always that simple. Sometimes your body will respond differently if you've exercised more, or if it's hotter outside, or if you're more stressed, or labels are lying and there's more carbs than it said. So it can be really tricky living with type 1 diabetes. It's a constant math problem and constant guessing how much insulin to inject. And so the most common cause of hypoglycemia is injecting too much insulin. A person, usually somebody with type 1 diabetes, will inject too much exogenous, so from the outside of the body, exogenous insulin, which will cause their blood sugar to drop too much. They'd have too much insulin and it will drop too much. Like I said, that's by far the most common. It's about 50% of all cases of hypoglycemia. Fasting hypoglycemia is something that occurs, as you might imagine, after a fast. It occurs after an overnight fast, between meals, or after physical activity. And this is usually due to some other type of syndrome, typically things like an enzyme deficiency, which is a genetic thing, cancers, or severe kidney or liver disease. Because as we're going to kind of learn later, again, we try to talk about these symptoms. We try to separate them out and talk about them one at a time. And it's never that easy. It's never that simple. And when one system starts to fail, it can affect lots of other parts of the body. And one of the ways that liver disease and kidney disease can affect the body is causing fasting hypoglycemia. It can be very severe, but it is relatively less common, much less common. It's fairly rare. And it's often, like I said, genetic or secondary to other conditions. Okay, and then the last type is reactive hypoglycemia, which is an interesting thing. And it's a hypoglycemia that occurs 2 to 4 hours after eating. And this is due to a delayed and exaggerated increase in insulin. So approximately 2 to 4 hours after eating, instead of releasing insulin into your blood right after a meal, as is supposed to happen, what will happen is your body will delay the onset of insulin release, and it will release too much. It's kind of an interesting thing, but your body releases too much insulin, and it is often caused by GI surgery. So again, gastrointestinal surgery, the gastrointestinal tract is attached to your pancreas. So gastrointestinal surgery can affect your pancreas. And I know some of you have met her now, but I have a friend who had very severe ulcerative colitis, and she had to have her entire colon removed not that long ago, about a year ago. And she, after her GI surgeries, they actually had to check her glucose levels every hour on the hour because they fluctuated so wildly. And it's a very common thing to happen because when you go through a major surgery like that, your body kind of freaks out. That's the best way to say it. Inflammation and stress from the surgery can cause a lot of things to happen. And one of them is that your pancreas doesn't act right. Sometimes it produces too much insulin, sometimes it doesn't produce enough. So this reactive hypoglycemia is something that can happen after a GI surgery or early onset of type 2 diabetes. So when your body starts to have that insulin resistance, one of the things that it will do to try to compensate is it will release more insulin. And since your body isn't completely resistant to the insulin yet, this is like the early stages of type 2 diabetes, it can cause this reactive hypoglycemia. Right? So another type of diseases, and this is a group of diseases that we're not going to talk too much about, but it's glycogen storage diseases. So like we talked about, glycogen is the storage form of glucose in humans. What's supposed to happen in a typical human is blood glucose is supposed to be pulled into the cells by insulin. Insulin causes the glucose to move into the cells where it is converted into glycogen and then taken to the liver and stored there for later use. What we're supposed to be able to do is at some point take that glycogen and convert it back into glucose when we need energy. But these glycogen storage diseases are a group of genetic diseases that result in a defective or missing enzyme somewhere in the metabolic processing or storage of glycogen. So that can be, like I said, in the processing of glycogen, in the making of glycogen, in the storage of glycogen, or the metabolic processing of glycogen back to glucose. So this is a group of disorders. There is glycogen storage diseases type 1, 2, 3, and 4. It can include lots of different enzymes and things like that. Symptoms vary because, again, it is a group of diseases. But it can include, it's basically, again, since glycogen can't be stored or metabolized, the patients suffer from long-term hypoglycemia, which again is basically like they're starving. The patients are constantly, they do not have enough carbs to run their bodies. And so they'll have muscle wasting and things like that because their body is trying to produce food. It doesn't have enough carbohydrates, and so the body will start breaking down muscles to try to produce foods. Okay. And we're not going to talk about all of these types, but we are going to talk about type 1. So type 1 glycogen storage disease is called glucose 6-phosphatase deficiency, also known as von Gierke's disease. And this is the only one that you have to know, like, the pathophysiology of. And what this is I'm recording this in the middle of a thunderstorm, so I'm making sure that I don't have crazy warnings or anything. So it is a loss of an enzyme for the conversion of G6P to glucose. So what this basically is in the process of glycogen being converted back to glucose, we have an in-between stage called glucose 6-phosphate or G6P. So kind of in the middle here, when we're going from glycogen to glucose, we will take this glycogen and it will be converted to glucose 6-phosphate or G6P, glucose 6-phosphate, and then it will be converted to glucose. The enzyme that converts glucose 6-phosphate to glucose is this one right here, this glucose 6-phosphatase. Okay, it removes the phosphate group from G6P and makes glucose. Well, if we do not have this enzyme, then G6P cannot be converted into glucose. So we will not be able to process glycogen into glucose. glycogenolysis cannot occur. And so because this glycogenolysis cannot occur, there will be a buildup of glycogen in the liver, and the patient will experience chronic hypoglycemia between meals. Okay, so the symptoms will be things like severe hypoglycemia, growth restrictions. Over time, there can be an increase in the size of the liver. Because of all of that glycogen buildup. And it can lead to chronic liver disease. And it can be a very, very serious condition, which can lead to death if it is not treated properly. So that is type 1 glycogen storage diseases. But there are others. We're just not going to talk about them. Okay. And then I believe our last kind of carbohydrate deficiency or carbohydrate disease we're going to talk about is something called galactosemia. And galactosemia is an inborn error of metabolism. And that's kind of a fancy way, or a more specific way, I suppose, of talking about a genetic deficiency. And it's usually a genetic enzyme deficiency. So an inborn error of metabolism is a disease in which a person is born without a particular enzyme, which will affect a particular enzyme metabolism pathway. And in this one, galactosemia, the enzyme that is lacking is a complete lack of the enzyme galactose 1-phosphate uridyl transferase. Okay. You don't necessarily have to memorize that name, but you do have to know what process that it is involved in. And this, again, is really key to this galactose. So galactose is a type of sugar. It is a monosaccharide. Galactose is a monosaccharide mostly from the breakdown of lactose. And what our body does in a typical body, what will happen is this galactose will be converted into G6P, which is what is used in glycolysis, which is what our body uses to produce energy. So that is how energy is created in our body, is by using this glucose 6-phosphate to go through oxidative phosphorylation and the Krebs cycle and all that fun stuff, glycolysis, to produce energy. And in galactosemia, patients do not have this enzyme that converts galactose into something that our body can use to make energy. And this is particularly dangerous. Sorry, the storm is going outside. I'm distracted. So this is particularly dangerous in newborns. Because a newborn, a baby mammal, is going to get by far most of their calories, if not all of their calories, from the lactose and galactose in breast milk and or formula, because their diet is mostly consisting of lactose and galactose. So a newborn, most of their carbohydrates, most of their sugar, most of their energy in their diet is coming from lactose and galactose in breast milk or formula. If a newborn cannot convert this galactose into G6P to be used in glycolysis, they cannot produce energy, or they cannot produce enough energy. In an adult, this is much less of a problem, because adults, you can just not eat dairy products, right? And a human adult can get carbohydrates from a lot of different places other than lactose and galactose. But newborns, their primary food source is dairy products, lactose and galactose. So galactosemia is actually among the most common carbohydrate disorders. It occurs in about 1 to 30,000 live births, which doesn't sound like a lot, but there are tens of thousands of babies born every single day in the United States alone. So 1 in every 30,000 live births is actually relatively common. And because that galactose cannot be utilized, the galactose builds up in the blood, and the galactose in high amounts can lead to a lot of different things: jaundice, diarrhea, vomiting. But the big one is this failure to thrive. So this failure to thrive, seizures, and brain edema, which is a fancy word for swelling, brain swelling. But this failure to thrive is exactly what it sounds like. It's kind of an official term for this baby is not growing. This baby is not doing well. The baby is not getting bigger. It's not meeting milestones. It is failing to thrive. It's not growing the way that it should. And galactosemia, again, is a metabolic disorder. And so this is why if you ever have a baby, or if any of you have babies, or if you ever have one, this is why one of the tests that they perform on a newborn heel stick. So most babies born in the United States, kind of again, if you go to a traditional doctor, midwife, anything like that, your baby is going to get what's called a little heel stick at birth, where they poke their heel with a needle and they collect a little bit of that blood. And that tiny amount of blood is used to test for a series of metabolic disorders. We'll talk more about some of them later, but galactosemia is one of those disorders that is tested for. And the reason for that is because galactosemia can lead to failure to thrive, seizures, brain edema, and if it is not treated quickly, can lead to permanent brain damage, other disabilities, and even death. So, and it can be managed. Galactosemia can't really be treated, but if you can feed newborns, they have special formula that does not have lactose and galactose in it. They use other types of sugars. So this disorder, if it is caught, can be managed relatively easily. So that's why those heel sticks are really important. It's to kind of catch some of this stuff before an infant starts to show symptoms of that. Because if you catch galactosemia on that newborn heel stick, a lot of times their metabolic disorder will be caught before they start to show this failure to thrive, brain swelling, things like that. So that is galactosemia. All right, so those are the only carbohydrate disorders that we're really going to talk about: diabetes mellitus, all 4 types, hypoglycemia, the glycogen storage diseases, specifically type 1, and galactosemia. Okay. So now we're going to move on to how blood glucose is tested for within a clinical laboratory. So how do we test for it? What is the collection like? How do we handle blood specimens, things like that, when we are testing for blood glucose within a laboratory? And this is going to be a common theme as we move through this class. We are going to talk about what it is that this test is telling us. So, we talked about what the normal ranges of blood glucoses are, and what it means for a blood glucose to be normal, what it means if it's high, what it means if it's low, what types of diseases would cause that. And then we're also going to talk about kind of the bread and butter of clinical chemistry is how do we test for that? How do we collect it? What kind of sample is needed? What are the limitations of this test? How is it tested for? Okay, so we're going to spend a lot of time talking about collection techniques, handling techniques, all kinds of stuff throughout this class. So this is just our first one. But blood glucose levels can be performed on serum, plasma, or whole blood. So if you've never taken a class where they've talked about human blood before, human blood can be broken up into kind of 3 different parts, I guess, 2 or 3, depending on how seriously you're taking that separation. The first part is either the plasma or the serum. So that's kind of this, when your blood is separated out from each other, this kind of yellow clear part is the plasma or the serum. It is plasma if the tube that is collected in has an anticoagulant in it. So plasma is going to have clotting factors in it. We'll talk about clotting factors more later, but clotting factors are a bunch of proteins and vitamins that make your blood clot. If we add an anticoagulant to our blood, the clotting factors that would normally be used up when there is a clot will not be used up because we added an anticoagulant. So a plasma is using the anticoagulant, and a serum is when there is no anticoagulant, and so there will not be any clotting factors left because the blood will have clotted. All those proteins and vitamins will be pulled together into a blood clot, and they'll basically be pulled out of the liquid portion of the blood. So plasma and serum are not exactly the same, but a lot of times people use those words interchangeably. Especially, there will be a few tests where you have to use specifically plasma or specifically serum, and we'll talk about what those are. But a lot of times these tests, it can be plasma or serum, and it doesn't matter. So that is the first part of a blood sample, is going to be basically the liquid portion. This is where all of the electrolytes and proteins are, any kind of double checking on the storm. Any type of nutrients, proteins, all that kind of stuff is going to be floating around in the plasma and or the serum. And then the bottom half, or the other part, are going to be the cells. And this is where all the cells are, both the red blood cells and the white blood cells. And the reason I said that your blood could be broken up into 2 or 3 pieces, depending on how serious you're taking that, is if you separate out your blood, you will actually also get a layer of red blood cells and then a very, very small layer of white blood cells. And you can see them kind of separate out. But you have a cellular portion with all your cells in it, and then you have the liquid portion with all the other stuff in it. Electrolytes, carbohydrates, proteins, all that fun stuff is going to be floating around in the plasma and or serum. So when we are collecting red blood cells, let me make sure I said everything that I wanted to. Okay, so most clinical labs, when testing for blood glucose levels, will use either serum or plasma. It doesn't particularly matter for blood glucose. There will be tests where it absolutely does matter, but for this one, it does not. And so we're looking at 2 separate kind of things here, is how we test for it inside of a hospital or a doctor's office, where we're using laboratory instruments within a clinical lab. And then we have a set of testing that is specifically done for self-monitoring glucose systems, which are typically used in homes. So it is very common, again, especially for people with type 1 diabetes, sometimes type 2 diabetes, for you to be able to check your blood at home. People with type 1 diabetes have to measure their blood glucose levels constantly to keep an eye on what their blood glucose is doing, and in order to control it properly. And then we've all kind of seen these like self-monitoring glucose systems at home, where it's like the tiny little poke, and then the person will like touch the the little piece of filter paper to their blood and it measures their blood sugar in just a few seconds, or the wearable glucose monitors that are, stuck to people's arms. And those different types of instruments, the clinical laboratory instruments versus the self-monitoring at-home glucose systems, use different types of specimens. So for clinical laboratory instruments, they use plasma or serum. Okay, doesn't matter, either plasma or serum. But it is really important that the red blood cells, or RBCs, I will frequently abbreviate red blood cell to RBC. And the RBCs should be separated within an hour by centrifuge from the plasma or the serum, because those cells will continue to perform glycolysis. Okay, so cells perform glycolysis. If you leave the serum and or plasma in the same tube with the red blood cells, those red blood cells will continuously do glycolysis, and the blood glucose in that tube will falsely decrease over time. Which is not what we want. So if testing is going to be delayed beyond an hour, one of two things needs to happen. If testing is completed within an hour, which is what is very common, like in a large hospital, in large hospitals, specimens are typically collected, sent right down to the lab, and run within 20 minutes, half an hour. An hour is generous time. But in situations where like doctor's offices or smaller labs, a lot of times they will collect blood throughout an entire day and then send it all over to the lab at once. So if you've ever had like your blood drawn in a doctor's office, a lot of times those tubes get labeled, slapped in a bag, and then they hang out in the doctor's office all day until they're sent to a lab. So if specimen processing is delayed by an hour, you can do one of two things. You can either separate the red blood cells by using a centrifuge. So a centrifuge is going to remove the red blood cells from the plasma, like you see here, where you can see the plasma and then the blood cells down at the bottom. And then this plasma can be pulled off using just a pipette or something else. So they either need to be separated using a centrifuge, or a lot of times if a doctor's office doesn't have a lab, they're not going to have a centrifuge either. So if this is a situation where there is no centrifuge, it's actually required that the specimen is collected in a special type of tube, and it's called a gray top tube, which has something called sodium fluoride in it. And this sodium fluoride is going to inhibit glycolysis. Okay, so if testing is going to be delayed by 1 hour, the specimen either needs to be separated, where the plasma and or serum is removed from the red blood cells using a centrifuge, or you can collect in a sodium fluoride or gray top tube, which will stop glycolysis. Okay. Now, these self-monitoring glucose systems often use whole blood. Like I said, we've kind of all seen that, where it's like the finger stick and then the tiny little piece of filter paper that measures the blood glucose really, really quickly, or those wearable glucose systems. Obviously, those wearable glucose systems and those tiny little filter papers are not separating plasma from red blood cells. Those systems use whole blood. Okay, they don't just measure from plasma, they just take whole blood, meaning the red blood cells, the white blood cells, and the plasma all mixed together. Just the blood as it comes out of the body. Now, it's important to remember that whole blood measurements are actually about 15% less than serum and or plasma, because those red blood cells physically take up about 10 to 15% of space within that tube. Okay, so remember that we're measuring weight per volume here. The measurement is milligrams per deciliter. Because we're doing a weight per volume measurement, the red blood cells taking up space removes or takes up space in that volume, I guess. So whole blood measurements are always going to be about 15% less than serum or plasma, which is what is expected from them. Okay, so this is just a little mini case. Again, read it and try and answer it yourself before I do it. But Twyla, a CLS student, drew a gray stopper tube for a glucose on a patient. She also performed a whole blood glucose on a glucose meter. The whole blood glucose result was 76 milligrams per deciliter, and the plasma glucose was 90 milligrams per deciliter. Are these results credible? And what we're asking for here is, do these results make sense? And the answer is yes. These results do make sense. And the reason they make sense is because this whole blood glucose result is about 15% lower than the plasma glucose. So these two results, even though they are different, the plasma glucose from the gray top tube was about 90 and the whole blood was about 76 in the same patient. Even though those two results are different, it makes sense because whole blood glucose measurements are typically about 15% lower. Right. Now we're going to talk about how we measure these. And I know that this kind of learning, I guess, can be a bit overwhelming at first. This is going to be, I know a lot of you are, I think we have a couple chemistry majors in here, but I know a lot of you are scared of chemistry and don't like organic chemistry. It's hard. This is about as technical into chemistry as we are getting. Most of you probably know more about organic chemistry than I do at this point, because I haven't taken organic chemistry in close to 15 years. So you guys probably know more about it than I do. This is the extent of chemistry reactions that we are going to be going into in this class. So we're not going to be talking about, how electrons move and tracking and balancing chemistry equations and things like that. This is the extent of it. So hopefully it's not too bad. So talking about glucose methodologies, these are the tests that we do to test for glucose in a lab or in a home glucose monitoring system. This is how we take a tube of blood and figure out how much glucose there is in this person's blood. And our first method is something called glucose oxidase. And a lot of these reactions are going to be what we call two-step reactions. And they will consist of a primary reaction, which is a reaction with what we're looking for, and usually some kind of enzyme. This is just a generic thing. We'll talk about this more in just a second. And then the second reaction is often what we call an indicator reaction. And the indicator reaction is something that it's a reaction that causes a change that we can visibly see or measure, whether that's something that can be measured with a spectrophotometer or a mass spectrometer or lots of different things, but a lot of chemistry is used like spectrophotometers. But there is this two-step kind of reaction process. We have this primary reaction and then an indicator reaction that usually creates some kind of measurable change. And this is going to be a very common theme as we go through this class. So kind of get used to seeing this two-step primary and then indicator reaction. So in our first methodology for glucose, this is the glucose oxidase methodology, also known glucose oxidase and peroxidase because of that peroxidase secondary reaction, which is called GOD or POD, and it's also called the Trinder reaction. For my ASCP taking MLS majors, Trinder reaction, that word is something that the ASCP loves to ask you about. So the glucose oxidase methodology is called that because the primary reaction uses the glucose oxidase enzyme. So what we're looking at here is this glucose oxidase is what we would call the reagent. And what I mean by that is this is what we are adding to the reaction to make something happen. Okay, this stuff over here, the glucose, the oxygen, the water, these are the things that are in the sample. And always try to remember what our goal is here. Our goal of this sample, we're taking this person's blood and we are figuring out how much glucose there is. That is our final goal, is we know that there's glucose there. How much is there? So in order to figure that out, we add this reagent. We add this glucose oxidase. Okay. And what this is going to do is this causes the oxidation of glucose into something called gluconic acid. And as a result of that oxidation, we have the creation of, you add an oxygen to that water and you produce hydrogen peroxide. Okay, so that is the first reaction. The glucose oxidase reagent is added, and it produces gluconic acid and peroxide. Now, our secondary reaction, our indicator reaction, is going to be the thing that allows us to measure the change. Okay, and so what we're adding to this one, so the reagents are going to be yellow. So the reagents here are actually a chromogen and a horseradish peroxidase. Okay, this is another enzyme that changes hydrogen peroxide, basically. Okay, so we're adding a chromogen, which is a color-producing molecule. And we're adding it in its reduced state. Now, when this hydrogen peroxide, which was produced in this first reaction, is introduced to this chromogen and the horseradish peroxidase, what will happen is this chromogen will oxidize. And when it oxidizes, it changes color. And color changes are something that are measurable. Okay, so when we are looking at that first reaction, the conversion to gluconic acid and hydrogen peroxide, the production of hydrogen peroxide itself is not something that is visible. Hydrogen peroxide looks like water. We cannot visibly see the difference that has happened. We cannot see that anything has changed. But when we add this chromogen and this second enzyme, we oxidize this chromogen, and that produces a measurable color change. And you will get a lot of experience with this. We'll do this many times in lab. That's the point of lab, is you will do these reactions. You are going to add these reagents to patient sample and watch the colors change as the reactions happen. And so when we start doing this in lab, I think it's going to kind of bring it back around for everybody. But our, so again, we have two different reactions happening here. Our first reaction is the glucose oxidase, where that glucose in the patient sample is being converted into gluconic acid, but it's producing this peroxide. That's the big clue. And it produces peroxide at a rate that is comparable to the amount of glucose that there is. And when we produce this peroxide, it will react with the chromogen to produce a color change. And the amount that color change happens is going to be comparable to how much glucose there is. And again, that color change is measurable by instruments. Instruments can use lasers and lights and spectrophotometers and things like that to measure how much that color has changed. And how much that color has changed is going to give us the answer to how much glucose there is in that specimen. Okay. So the glucose oxidase procedure, again, uses a primary reaction of glucose oxidase and then a second indicator reaction using the horseradish peroxidase to cause a color change. Okay, so glucose oxidase is a relatively specific reaction. I think I have it. Do I have it on the next slide? Yeah, I do have it on the next slide. So when we're looking at this glucose oxidase methodology, it does have some limitations. It is a relatively good measurement. However, this indicator reaction is not highly specific, meaning that this indicator reaction down at the bottom, that chromogen is going to react with any hydrogen peroxide. And it actually also reacts with several other things. So that indicator reaction isn't always specific to the glucose measurement. And so those interfering substances, the indicator reaction is not highly specific. And so we have a couple of, I'm really distracted. The storm is just raging outside. I'm sorry for getting distracted. I'm sorry, I'm trying to bring it back in. So we will have some interfering substances because that indicator reaction is not very specific. Specifically, a lot of these acidic substances, uric acid, ascorbic acid, and bilirubin, these are all acidic substances, and they inhibit the reaction by competing with the chromogen. So they will bind up, basically, they kind of bind up those hydrogen peroxides. They steal the hydrogen peroxides away. And because those hydrogen peroxides are being stolen away from that indicator reaction, if we're losing peroxides before they can get to this reaction down here, the glucose measurements will be falsely lowered. On the other hand, strongly oxidizing substances like bleach, particularly like bleach, can oxidize that chromogen on their own and can falsely elevate glucose results. And bleach can be, I'm not going to go into too many details there, but just anything that is a strongly oxidizing substance can oxidize the chromogen on its own. This reaction is not all that specific. So the biggest disadvantage of the glucose oxidase is that interfering or that indicator reaction is not highly specific. There's a lot of things that can cause falsely lower glucose measurements and falsely elevated glucose measurements. The major advantage to this glucose oxidase is it's incredibly cheap. It's a lower cost, and it's mostly useful when measuring blood glucose in at-home monitoring devices. Because the truth is that these at-home monitoring devices don't need to be horrifically accurate. They do need to be semi-accurate, but it's not incredibly important that we have the exact number. For a lot of these at-home monitoring devices, if something says that their blood glucose is 80, it doesn't matter if their blood glucose is actually 70 or if it's actually 90. We know the basic range. So for these at-home monitoring systems, the decreased sensitivity, the decreased specificity is an acceptable payoff for the lower cost, because people at home cannot afford to pay for these higher cost methodologies, if that makes sense. So its major advantage is its lower cost, and it's most often used for these in-home glucose monitoring systems. Sorry about that. All right, so our second methodology for glucose is hexokinase. And hexokinase is another two-step reaction. It is much more specific, mostly because of that indicator reaction. The indicator reaction here is much more specific than the horseradish peroxidase one. Okay, and this is a indicator reaction we are going to see a lot because it's a really good indicator reaction, and it gets reused a lot. So again, this is hexokinase, and it is a two-step process. Hexokinase, put it in yellow, because what we're adding here, these are the reagents. The reagents here is this enzyme hexokinase, and then a divalent cation called magnesium. Mg stands for magnesium. So in the presence of magnesium, hexokinase takes this glucose, which is, remember again, this is the patient sample. So in this patient sample, when you add hexokinase and magnesium to glucose, it will convert it into this glucose 6-phosphate and ADP. Okay. So hexokinase catalyzes the phosphorylation of glucose to form glucose 6-phosphate. And then the second reaction, this indicator reaction, is you add this glucose 6-phosphate dehydrogenase. So this is our reagent in yellow. And in blue, this glucose 6-phosphate comes down here, catalyzes the oxidation of G6P and the reduction. This is the big thing here, is when you add, this NAD is also a reagent. So when you add this NAD, this glucose 6-phosphate is going to give up a hydrogen, basically, and form NADH. Okay, so it donates a hydrogen, and NAD is converted into NADH. And this is where the indicator becomes in, because this NADH results in a change of absorbance. So when NAD turns into NADH, it causes a change, an increase in absorbance at a specific wavelength. You don't have to memorize the wavelength that's written there. But a change in absorbance can be measured by spectrophotometer. Okay, and this reaction, this G6PD hexokinase indicator reaction, is much, much, much more specific. You are really only going to have the change of NAD plus to NADH when you have the production of glucose 6-phosphate. There are not a bunch of other things like uric acid, whatever else, that cause that change to happen. So this is a relatively specific and sensitive indicator reaction. Okay. So there are some interfering substances, and the interfering substances here are mostly things that interfere with a spectrophotometer. So we're going to be spending a lot of time, again, in lab using spectrophotometers, and so we'll talk more about them in lab. But in general, hopefully you've used one before. You use them in a lot of labs. Hopefully you've used one. But spectrophotometers use light and color to measure turbidity and color changes at specific wavelengths. But anything that interferes with the movement of light, or anything that has a very highly pigmented something is going to interfere. So what I mean here is some drugs, we'll kind of skip that for now, but hemolysis, what hemolysis does is this makes the plasma bright red. And we're going to talk more about hemolysis later. That is when the red blood cells break within the tube. Again, we'll talk more about that later. But what that will cause to happen is it makes the plasma bright red. Instead of that kind of goldeny yellow color that it's supposed to be, it turns it bright red. Highly elevated bilirubin, this makes the plasma orange or brown. Okay, so highly pigmented. You don't have to memorize all this stuff now, but just know that some drugs, hemolysis, bilirubin, those all cause incredibly pigmented plasma, which interferes with the spectrophotometer detecting color changes and absorbance changes. And then highly elevated triglycerides, this is going to make the plasma cloudy. So the plasma of somebody who has increased lipids, triglycerides, increased lipids and fats, their plasma will literally look like milk. It gets really cloudy and it turns white. And bacterial infections can make the plasma cloudy. So again, all of these interfering substances have very little to do with the glucose measurement itself, and just that they interfere with the spectrophotometer. They produce large pigment or intense pigments, like with hemolysis, bilirubin, things like that, or they block the passage of light because something is really cloudy or turbid, like with triglycerides. So that overall, this method is very effective. It has very few interfering substances, and those interfering substances, again, don't have anything to do with the glucose measurement. This is just a problem with the patient's sample. But the major disadvantage is the cost. It's extremely expensive. The sources of G6PD are often bacterial, and the production or extraction of these can be very expensive. So this is mostly used in clinical lab instruments and reference labs because it is much more accurate. And in clinical labs, at hospitals and doctors' offices, we need exact numbers. We can't just be dealing with kind of the range, right? So when we need exact numbers, like in clinical labs, things like that, they mostly use hexokinase methodologies. Okay, so those are the two major methodologies that measure glucose. Glucose oxidase, again, is very effective. It is less specific, but it costs less, but it is useful for at-home monitoring systems. And then hexokinase is highly specific. It's a really good measuring tool, but it has a really high cost. So it's mostly used within clinical lab instruments. Okay. So those are our blood glucose reference ranges. We talked about these on a couple of different slides, but this is it just kind of popped onto one slide. Yeah, and you do have to memorize these. So yes to memorizing. It is required that you memorize these. And you also need to remember that all of these are plasma measurements. These are plasma or serum measurements. Remember that whole blood is about 15% lower. Okay. All right, now we're briefly going to talk about urine glucose. So something that can be really useful when we're testing for diabetes is something called urine glucose. And this is the amount of glucose within the urine. Like I said before, glucose in the urine is not normal. And so testing for it can be helpful in diagnosis of certain types of diabetes. So urine glucose is measured semi-quantitatively in urine, which means that there's not an actual number. It is usually just measured in terms of there's none, there's a little, there's some, there's a lot, there's really a lot, basically. And that is what the 1+, 2+, 3+, or 4+ means. So results are reported as negative, or 1+, which means there's a little bit, 2+ means there's a little bit more, 3+ means moderate to high, and then 4+ means really, really high. And then sometimes they're given approximate glucose ranges. And this is measured semi-quantitatively through the glucose oxidase measuring methodology. Okay, and this is what that looks like on a urine strip. Usually glucose measurements are done with these little strips that you dunk in the urine, and then they will turn a specific color based on how much glucose there is. Okay, and we're not really going to worry about this right now. We'll talk more about that when we get to urinalysis. So you can just kind of ignore that for now. Okay. Now I briefly want to talk about cerebral spinal fluid glucose. Cerebral spinal fluid glucose, also known as CSF. Cerebral spinal fluid, if you don't know, is the fluid around your brain and spinal cord. Your cerebral spinal fluid serves a lot of purposes, but the biggest purpose, or one of the biggest purposes, is that it provides some nutrients to your brain, and it also cushions your brain so that your brain doesn't smack the inside of your skull every time you move your head. Okay, so your brain and your spinal cord are floating around in this cerebral spinal fluid. It's what kind of protects the brain from the rest of the body and from hitting any bones on the inside of your body, I guess. So cerebral spinal fluid glucose can be measured by either glucose oxidase or hexokinase. It doesn't matter. It's the same kind of ideas for both. Now, the reference range for cerebral spinal fluid glucose is between 50 and 80 milligrams per deciliter most of the time. The other thing that we have to take into account here is that a person's cerebral spinal fluid glucose should be about 60 to 70% of their plasma glucose. So when you are measuring a CSF glucose or a cerebral spinal fluid glucose on a person, you should always draw a blood glucose at the same time for comparison. Now we use cerebral spinal fluid glucose to test for, this is a really key test in testing for bacterial or fungal infection of the CSF, also known as meningitis. So, and the reason that this is a useful test is because bacteria and funguses are living organisms, right? They are living cells, living organisms. Living cells use glucose to survive. So if somebody has bacteria or yeast, a fungus growing inside their brain, inside their cerebral spinal fluid, what will happen is that bacteria and or fungus will literally eat the glucose out of their brain fluid, out of their CSF. So a decrease in CSF glucose relative to the blood glucose can be indicative of a bacterial or fungal infection in the CSF. But that relative to blood glucose is absolutely key. Okay, so you always have to compare the CSF to the blood glucose drawn at the same time. Now, this is a good case here. This is a little mini case about Ken had a cerebral spinal fluid drawn in a red stopper tube and a red stopper tube. This is serum. Okay. A red stopper tube is used for serum. And the laboratory results were as follows. The serum glucose was 80 milligrams per deciliter, and that CSF glucose was 40 milligrams per deciliter. Okay. So are these two glucose results consistent with what you would expect? Okay. And the answer is no. The reason is this right here is a normal serum glucose. Okay. This CSF glucose is a little bit low in absolute terms, meaning that we expect it to be between 50 and 80. So 40 milligrams per deciliter is a little bit low, but we would expect the serum to be about 60 to 70% higher, or the CSF glucose to be about 60 to 70% of the serum. In this case, the CSF, if you divide it by the serum, that's about 50%. So not about, it is 50%. So in this case, the CSF glucose is 50% of the plasma glucose. So these two results are not consistent with what we would expect. Okay. That serum glucose is normal, but that CSF is decreased. That CSF is decreased. Not only is it just low on its own, but it is only about 50% of the serum glucose of this patient. So this is not what we would expect. So what is the relationship between the serum and the CSF? Like I said, this patient's CSF glucose is about 50% of the serum, which is lower than expected. One possible explanation for these results, like we just talked about, a bacterial or fungal infection. Okay, this patient is losing glucose inside their brain. Okay. All right, and then we're going to talk about two more things that can be useful when we're talking about carbohydrate metabolism and testing for carbohydrate metabolism. And then we'll be done. So the first one is ketones. What ketones are substances that are produced in the body during ketoacidosis. And which is a state in which the body uses lipid stores and sometimes muscle tissue in high amounts because carbohydrates are unavailable. Remember, we talked about this when we talked about diabetes mellitus, particularly type 1 diabetes. So this occurs in uncontrolled diabetes mellitus when lipid stores are used for energy. Lipid stores and muscle tissue are used for energy because the carbohydrates are unavailable. And there are three that are produced: this beta-hydroxybutyric acid, acetoacetic acid, and acetone. You do have to know those names. Okay, beta-hydroxybutyric acid, which is the most, acetoacetic acid, and then acetone. These are the three ketones that are produced when ketoacidosis is happening. But during extended ketoacidosis, the ketones are going to build up in the blood. And that buildup in the blood is called ketonemia. So emia, as a prefix, it always is going to mean in the blood. And urea is always going to mean in the urine. So ketonemia is excessive ketones in the blood. And ketonuria is the presence of ketones in the urine, or excess ketones in the urine. And these ketones actually produce kind of a fruity odor. Fruity is a weird term for it, but if you've ever smelled acetone, acetone smells kind of fruity. It's a weird, like astringent smell, but if you smell acetone, it does have kind of a fruity undertone. And that smell is characteristic of people in uncontrolled diabetic ketoacidosis. Their breath will smell fruity and their urine can smell fruity. That is one of those things that caregivers, doctors, nurses, and things like that are capable of smelling on a patient and saying that this person is in diabetic ketoacidosis. But so what we're testing for here is you can test the serum or the urine for the presence of ketones, specifically acetoacetic acid. This is the one that we typically test for using this sodium nitroprusside. So the methodology that we use for measuring ketones is sodium nitroprusside. And the reason is this acetoacetic acid, I have it down here, this acetoacetic acid, when you add sodium nitroprusside, so this, remember, is the reagent in yellow. This is what we're adding. This is what is in the patient's urine or serum, so in the patient. When you add sodium nitroprusside to acetoacetic acid, it produces a purple color. Okay. And so this is what those results will look like. They're actually these little tabs that you add. These tabs have sodium nitroprusside in them. And when you add patient urine or serum to the top, if there is ketones, the little tab will turn purple. Okay. And ketones are always produced in the same percentages, right? The 78, 20, and 2%. So even though we're only testing for acetoacetic acid here, this is enough to tell us that the ketones are there. Notice that this number or this result is not a number. This is a semi-quantitative test, meaning that we're not getting a specific number here. We're saying, yes, there are ketones there. There's a small amount, there's a medium amount, or there's a large amount. It's a semi-quantitative test. So even though we're only specifically testing for acetoacetic acid here, it is enough to tell us, yes, ketones are present and the approximate amount. Right? And then this is the last one that we're going to talk about, and this is glycosylated hemoglobin. And this is a relatively new test. It's not new, but it's relatively new in terms of diabetic management and things like that. And what this is glycosylated hemoglobin. Hemoglobin is a red blood cell protein that carries oxygen. We'll talk again more about this later, but hemoglobin is a protein found inside of our red blood cells that carries oxygen. And when in the process of a red blood cell existing, in the 120-day lifespan of a red blood cell, sometimes that hemoglobin has a glucose molecule attached to it. And that is what glycosylated hemoglobin is, or hemoglobin A1C. That's another name for it. A1C. So glycosylated hemoglobin or hemoglobin A1C is when this hemoglobin inside of a red blood cell is exposed to sugar. Sometimes that sugar gets attached to the hemoglobin. And glycosylation occurs over the entire 120-day lifespan of a red blood cell. And glycosylated hemoglobin is a completely normal thing within every single person. All of us, typical people, people with diabetes, everybody has some amount of glycosylated hemoglobin because your red blood cells are always going to be exposed to some amount of sugar. That's very normal. Your body has sugar in it. It's supposed to. However, if a person has more sugar in their blood than is typical, if they are always hyperglycemic, their hemoglobin A1C level, the percentage of their hemoglobin that is glycosylated will go up. So in a typical person and somebody who does not have diabetes, the percentage of A1C is usually is less than 6, less than 5.7, I guess. And then somebody with diabetes, their hemoglobin A1C percentage will increase based on their estimated glucose levels. Now, the cool thing about glycosylated hemoglobin is that it measures glucose levels over the entire lifespan of red blood cells. So it is thought that glucose, or that glycosylated hemoglobin, is an average of a patient's 3-month glucose levels, 120 days. So the reason that this is really cool is because it gives us a much more accurate picture of how well a patient is doing at controlling their glucose levels, specifically people with type 2 diabetes, whether they're on medication or they're just trying to control it with a diet. Because if a person has type 2 diabetes and they are not that great at controlling their glucose, what they can do is a lot of times these patients get really, really good at controlling their glucose the 2 days before they go to the doctor, right? They'll control their diet. They'll eat really, really well 2 or 3 days before they're supposed to go to the doctor. And then they do their fasting plasma glucose, and it's great because they have been eating well for 3 days. But the hemoglobin A1C is not tricked that way because it is looking at the glycosylation of their hemoglobin over a 3-month period. So it is often used to monitor long-term glycemic control in patients with diabetes. And you don't have to memorize this formula down here, but it is just important to note that this kind of thing exists. So the percentage hemoglobin, the percentage of glycosylated hemoglobin, can be used to calculate an average estimated glucose. So a person who has, an 8.5% A1C, their estimated average glucose over the last 3 months is 197. So you can see, again, this is looking, it can't be affected by recent diet. This is not something that can be faked, unlike a fasting glucose. A fasting glucose can be kind of padded a little bit. If somebody controls their diet a couple of days before they have their blood drawn, their fasting glucose can appear more normal. But this glycosylated hemoglobin gives a much more accurate picture. All right, and then this last one, I'm actually going to cross this out. We're skipping this for now. I don't really know why I talk about it here. We'll talk more about microalbumin when we get to proteins. All right, so I think this is where we're going to call it. Feel free to ask me any questions on this. You're welcome to email me. I will be in the building Monday afternoon. This is also your reminder that there is no labs this week. So the week of March 16th, there are no labs, but your QC assignment is due next Monday. So don't forget about that. All right. So I'm sorry I did have to post a lecture instead of coming to class, but it was just a necessary thing. I don't like to do it, but sometimes we have to. So yeah, feel free to email me if you have any questions.